the 3D is a revolutionary technology to change the way a surgeon performs VR surgery. And Dr. Prashant Bhavantle was ahead of me. Benefits both the surgeon and the patient, and be a widely accepted platform in the future. But I think myself, Prashant, we are totally into that. Traditional VR surgery, the posture is difficult to maintain, leads to musculoskeletal pain, discomfort in the long run. All this is there, but I think more than that, this is Ingenuity, which no financial interest. I don't use Ingenuity, but I've tried it, and this is a 3D high definition camera, and this is how the Ingenuity is fixed, and I use the RTO. The benefits of the 3D digital surgery is that improved ergonomics, posture at the maximum for several hours. You can sit back and operate. And then with the surgical field displayed on a unit placed at a convenient position, the surgeon can maintain an ergonomically neutral position. This reduces musculoskeletal fatigue for the surgeon. But I always say, you don't have to need a 3D VR surgery for that, or a head-up surgery, which Klaus Eckhart calls it. I think you have to do exercise, have the protagonist and antagonist muscle, abdomen and back muscles strong, as well as do dance. And that's what is important. This is the beautiful surgery where you can, everybody in the whole OT can see. And then this is how you can adjust, and there is a separate monitor for recording. And then the recording comes beautiful, and you can see the TV how. And how does 3D apply in ocular trauma? Here I've used this, and I've actually recommended to Kashmir because they have everything. But they don't have the 3D surgery. I want them to have a center of excellence, particularly for ocular trauma in for the Kashmir Valley and the northern India, north of Delhi. So the pellet injuries range in severity from contusion with a small hyphema to rupture of the globe with the uveal prolapse, retinal hemorrhage and detachment, optic nerve contusion, glaucoma and intracranial penetration. And these injuries have a very poor prognosis. And all these publications show that vitreoretinal surgery can offer some hope. And then intraorbital projectile foreign bodies can be a source of significant ocular morbidity. So with all this background, I made a trip to the mission Kashmir, where as a visiting surgeon to the government of J&K, reaching out to the helpless pellet victims. There were 2,011 surgery pellet injuries. Primary wound repair was done in 951 surgery patients, and total vitrectomy was done about 501. And this I have done about 200 plus myself. And this is how the scene looks at Kashmir in 2016, when July 8th, Burhan Wani was killed, and then the streets were deserted. And then suddenly the people will come and pelt stones at the police. And the police, to protect themselves and to disperse the crowd, they have to use the pellet guns. And even though they've been asked to hit below the knee, these people bend down and take the bullet pellets on their face and body, and you can see how it is here. And this is a 34-year-old male student, was presented with a history of penetrating ocular trauma with a pellet in the right eye, who had undergone primary corneal tear repair with iris reposition with anterior chamber wash meticulously by Dr. Tariq Qureshi and team in Kashmir, in Srinagar, Sri Maharaja Hari Singh Hospital. And then the sixth day, the patient came to Kashmir. And these are the one or two patients who came to Mumbai. Rest, I told them, you'll be there, I'll come there and operate. On examination, the right eye was hand moved close to the face with traumatic cataract. B-score showed vitreous hemorrhage. CT revealed retrobulbar barometallic, or that means it has gone through and through into the back of the eye. And the patient was operated by us. And this was a pre-op photograph showing a cataract with the corneal sutures and the B-scan and the CT scan. And the anterior segment surgery was done by Dr. Kavita Rao, and she did the phaco aspiration, being a 34-year-old. So the advantage of using RTO, again, I don't have any financial interest. Kavita Rao sometimes uses the binoculars, but you can do a 3D recording. And if you don't want, you can just put the binoculars up and microscope part up, and then use the 3D glass and see the screen and operate. Now, I do anything, whether it's a buckle removal, belt buckle, vitrectomy, and I think I do everything with 3D. And this is a 23 gauge vitrectomy. Only thing is still we don't have technology, or maybe it's there. I'm trying to learn from Dr. Hunter from Orbis how we can transmit 3D surgery. Here you are a 3/4 partial vitrectomy is completed, and then because it's 6 days, as Dr. Ferenc Kuhn suggests, we should do in 100 hours the second repair, and that's about 4 to 5 days. And I think I do it 6 to 7 days maximum instead of 2 weeks, which was the second window before, where the blood is still in the liquid stage, in the subretinal space. And we do make a small 39 gauge retinotomy and drain the subretinal blood, and then do an endolaser, and then do a PFCL oil exchange or a air oil exchange, and then so that the retina is attached, and the endolaser is done around the 39 gauge retinotomy. And the idea is to reattach the retina and also remove if there is a pellet. In this eye, the pellet had gone through and through into the back of the eye, into the orbit. And after 6 weeks, you can see there's some corneal distortion. You can see the silicon oil reflection, retina was attached, finger counting 1 meter, intraocular pressure 9 millimeter. And how does 3D surgery help during ocular trauma? Offers better visibility in deformed globes. Trauma surgery is often long, takes more time than the average ocular surgery. Better ergonomics makes it more comfortable for the surgeon, allowing him or her to focus better on the surgery. The large screen makes it easy for the surgeon to coordinate hand movements while trying to retrieve intraocular foreign bodies. Trauma surgery often needs coordination of one of more assistant, and the large screen allows them to see better of what is going on and allow better assistance. What you see, the assistant sees, and the other people see. So I think I've got several videos, but I don't have the 3D videos. But I think I've shown these videos before. So my thing is to say that I do every surgery, not only trauma. We're using the 3D. But I think 3D has one thing is it can magnify, you can have less light, and then you can also digitally manipulate the images so that you can see better with the staining. And not only that, I always say that if there are two part of the paper like this, you can identify in such a magnified way, which you lose magnification in a microscope when you're seeing. The assistant may not be able to exactly appreciate what you are seeing. But here, he also uses a 3D glass, and he'll be able to see the nurse, the other, everybody will see. And it's an excellent teaching tool. And and it's like sitting back and operator. One day, the robot can take over the way operation is going on. And I think, thank you. The time is up.
Thank you, sir. Thank you very much for wonderful presentation again.
Yeah, the 3D.
I have one comment only that 3D is the future of ophthalmic surgery. I think after 5 to 7 years, you find that the microscopes may be phased out. It's so beautiful. I have experienced it. Whatever all Dr. Natarajan has mentioned, Professor Natarajan is absolutely correct. Fantastic experience. Only one disadvantage is there, that whatever you are doing is so many people can watch it and you cannot hide that you have done the retinotomy or you have touched the vessels or PCR. Other than that, it is fantastic.
No, but I think that helps you to become more honest, more truthful to yourself rather than patient or others. And it is like the best thing is to quality is you have to do something which others are watching or not.
Absolutely fine. And I have done pterygium, I have done femto, then AGV, all kind of surgery, the anti-segment, and I found it equally useful for anti-segment surgery.
So Prashant is my guru in the 3D surgery.
So he is Mahaguru for all of us.
Very good.
In fact, it is more than 4 years, and at our center we are doing right from pterygium to anything. In one theater, all surgeons are very comfortable. In fact, next month, July IGO, we are getting our publication on use of 3D surgery beyond retina, and it's for publication in IGO. You will see the use, how we use it. We have an experience now of more than 2,000 eyes.
Fantastic.
Prashant's ingenuity is always worth emulation.
Thank you, sir. Thank you for your kind